A 60-year-old male presents to the emergency department with fever, confusion, hypotension, and tachypnea. He has a known history of diabetes and hypertension. His vital signs are temperature 39 Dic, heart rate 112 bpm, respiratory rate 24 min, BP 88, 54 Hg. His initial lab work shows a lactate level of 4.5 mmol. What is the most appropriate initial management for this patient? Answer: this patient is presenting with signs of sepsis and likely septic shock as indicated by his fever, confusion, hypotension, and elevated lactate. The Surviving Sepsis Campaign guidelines recommend the following initial steps: immediate fluid resuscitation, administer 30 Ag of intravenous crystalloid fluid within the first 3 hours to improve perfusion. Given this patient's hypotension, BP 88, 54 Hg, fluid resuscitation is crucial. Antibiotic therapy: start broad-spectrum antibiotics within the first hour of recognition, even before obtaining culture results, to reduce mortality. The choice of antibiotics should cover common pathogens, e.g., gram-positive, gram-negative bacteria and fungi. Vasopressor therapy: if hypotension persists despite adequate fluid resuscitation, initiate vasopressors, e.g., norepinephrine, to maintain a mean arterial pressure map of 65 Hg. Evaluation: reassess the patient frequently for improvement and adjust treatment based on culture results and clinical response. What are the key diagnostic steps in identifying community-acquired pneumonia (CAP) in an adult patient, and how should it be managed in the emergency department? Answer: community-acquired pneumonia (CAP) is a common condition in the emergency department, and timely identification and management are crucial. The key diagnostic steps and management include clinical evaluation. Typical signs of CAP include fever, cough, sputum production, pleuritic chest pain, and shortness of breath. Risk factors such as recent hospitalization, immunosuppression, or chronic respiratory conditions should be assessed. Chest X-ray. A chest radiograph is essential to confirm the diagnosis of pneumonia and to assess the extent of the infection, e.g., lobar consolidation, interstitial infiltrates. Microbiologic testing. Obtain sputum cultures or nasopharyngeal swabs in severe cases, though empiric treatment is often initiated before test results return. Empiric antibiotic therapy. Start broad-spectrum antibiotics covering common pathogens such as Streptococcus pneumoniae, Haemophilus influenzae, and Mycoplasma pneumoniae. Use ceftriaxone plus azithromycin for inpatient treatment. For outpatient treatment, amoxicillin or azithromycin may be appropriate. Oxygen and supportive care. Oxygen should be administered if hypoxemia is present, SPO 90%. In severe cases, consider non-invasive ventilation, CPAP or BiPAP, or intubation. Mr. Ramirez, a 45-year-old diabetic male, presents with a red, swollen, painful area on his lower leg. There is overlying erythema, warmth, and fluctuation on palpation. His vitals are normal except for a mild fever, 38.2 Dic. His past medical history includes poorly controlled diabetes, and he has a history of chronic foot ulcers. What is the most likely diagnosis, and what are the next steps in management? Answer: this patient most likely has cellulitis with an abscess. The features of erythema, warmth, and fluctuance suggest a superficial soft tissue infection that may involve a purulent collection abscess. The next steps in management include incision and drainage, i.d. the most important intervention in this case is to drain the abscess if present. This is typically done under local anesthesia. Drainage is the mainstay of treatment for abscesses as it helps reduce the infection burden. Antibiotics. Initiate broad-spectrum antibiotics to cover Staphylococcus aureus, including MRSA, particularly in the setting of diabetes and a possible abscess. Empiric therapy with clindamycin or trimethoprim sulfamethoxazole (TMAMX) is appropriate until culture results are available. Wound care and monitoring. Proper wound care is essential, especially in a diabetic patient. Monitor for signs of systemic infection, e.g., sepsis, increased fever, and adjust antibiotics based on culture results. Consider imaging. If the abscess is deep or the diagnosis is unclear, consider ultrasound or CT imaging to assess for deeper involvement or complications like necrotizing fasciitis. A 72-year-old female presents to the emergency department with fever, confusion, and dysuria. She has a history of recurrent UTIs and hypertension. On examination, she is febrile with a blood pressure of 90/58 mmHg, heart rate of 112 bpm, and a respiratory rate of 22 min. Urinalysis shows leukocyte esterase and nitrites, and urine culture grows coli. What is the most likely diagnosis and what is the appropriate management? Answer: This patient is presenting with urocystitis likely secondary to urinary tract infection (UTI). The signs of fever, confusion, hypotension, and positive urine culture suggest that the infection has spread to the bloodstream, leading to sepsis. Management includes initial fluid resuscitation, administer 30 AAG of intravenous fluids to address hypotension and improve perfusion, empiric antibiotic therapy, start broad-spectrum antibiotics such as ceftriaxone or piperacillin tazobactam, which cover E. coli and other common uropathogens. Adjust the antibiotic regimen based on the sensitivity of the cultured organism. Vasopressors. If hypotension persists after fluid resuscitation, start norepinephrine to maintain MAP of 65 mg. Monitoring and support. Continuous monitoring of vital signs, urine output, and laboratory parameters, e.g. lactate levels, renal function, is necessary to guide treatment decisions. 32-year-old female is brought to the emergency department after being found unresponsive in her apartment. She is hypoventilating with a respiratory rate of 6 min and her pupils are pinpoint. Her pulse is 50 bpm and her blood pressure is 90/60 Hg. What is the most appropriate next step in management? Answer: this patient is likely experiencing an opioid overdose. The most important immediate treatment is the administration of naloxone, an opioid antagonist that reverses the effects of opioid toxicity. The steps to take are: naloxone administration. Administer 0.4 to 2 mg of naloxone intravenously, intramuscularly, or intranasally. If no response is noted, repeat doses may be necessary every 2 to 3 minutes up to a total of 10 mg until the patient responds. Airway management. Ensure the patient's airway is open and secure. Provide supplemental oxygen and assist ventilation if necessary, e.g. bag valve mask ventilation until the naloxone takes effect. Continuous monitoring. Once naloxone is administered, continue to monitor vital signs including respiratory rate, oxygen saturation, and cardiac function. Reversal of opioid effects may be transient, so close observation is necessary. Supportive care. Continue supportive care as needed, including intravenous fluids and monitoring for withdrawal symptoms after naloxone administration. MS Lawrence, a 28-year-old laboratory technician, accidentally spills hydrochloric acid on her forearm while working in the lab. She reports a burning sensation and notices redness and blistering at the site. What are the immediate steps in the management of her injury? Answer: chemical burns require prompt and careful management. For hydrochloric acid exposure, the following steps are crucial. Immediate decontamination. Remove the patient from the source of exposure. Flush the affected area with copious amounts of water, preferably running water, for at least 20 minutes to dilute and wash away the acid. Avoid using neutralizing agents, e.g. bicarbonate, as they can generate heat and worsen the burn. Remove contaminated clothing. Ensure that any clothing or jewelry contaminated with the acid is removed promptly to prevent further exposure. Pain management. Provide appropriate pain relief. This may include oral or intravenous analgesics. Wound care. After decontamination, the affected area should be covered with a clean dressing. In cases of extensive burns or deep tissue involvement, referral to a burn center may be necessary. Tetanus prophylaxis. Consider tetanus prophylaxis if the burn is large or if there is a concern for contamination. A 4-year-old child is brought to the emergency department after ingesting a bottle of iron supplements. On examination, the child is lethargic and has abdominal pain and vomiting. The serum iron level is significantly elevated. What is the best course of action for this patient? Answer: iron toxicity is a common and dangerous pediatric poisoning. The steps in management include assessment. Serum iron levels should be measured to confirm the diagnosis. Symptoms often progress in stages: gastrointestinal symptoms, nausea, vomiting, followed by metabolic acidosis, shock, and potentially hepatic failure. Decontamination. If the ingestion occurred within an hour, administer activated charcoal to limit further absorption of the iron. However, activated charcoal is less effective for iron toxicity compared to other toxins. Chelation therapy. Deferoxamine is the antidote for iron poisoning. It binds to free iron and promotes its excretion in the urine. It should be administered intravenously. Supportive care. Provide IV fluids and monitoring for shock, metabolic disturbances, and organ damage. In severe cases, hemodialysis may be required. A 24-year-old male presents to the emergency department with a sudden onset of headache, fever, neck stiffness, and confusion. His Glasgow Coma Scale score is 14. Cerebrospinal fluid (CSF) analysis reveals a white blood cell count of 1,000 cell, glucose of 5 mdl, and protein of 200 adl. What is the most likely diagnosis and the first-line treatment approach? Answer: this patient's presentation and CSF analysis are consistent with bacterial meningitis. The key findings are an elevated white blood cell count in the CSF, pleocytosis, normal glucose, and elevated protein. The next steps in management are empiric antibiotics. Start broad-spectrum antibiotics immediately after obtaining blood and CSF cultures. Common regimens include ceftriaxone or cefotaxime combined with vancomycin to cover Streptococcus pneumoniae and Neisseria meningitidis. If the patient is immunocompromised, add amphotericin B for fungal coverage. Supportive care. Provide fluids, manage fever, and monitor for complications such as cerebral edema or seizures. Isolation. Given the risk of transmission, place the patient in respiratory isolation until bacterial meningitis is ruled out or confirmed and proper precautions are taken. In the early management of sepsis, the Surviving Sepsis Campaign recommends specific bundles of care. What are the key elements of these sepsis bundles and how should they be implemented? Answer. The Surviving Sepsis Campaign bundle aims to provide early and aggressive treatment to improve outcomes in septic patients. The key components are initial resuscitation within 3 hours, administer 30 Ag of intravenous fluids for hypotension or lactate 4 mol. Obtain blood cultures before administering antibiotics when possible. Start broad-spectrum antibiotics within 1 hour of diagnosis. Vasopressor administration within 6 hours. If hypotension persists despite fluid resuscitation, initiate vasopressors such as norepinephrine to achieve MAP 65 mg. Monitoring and re-evaluation. Reassess the patient frequently for improvement and adjust interventions based on clinical response and laboratory findings, e.g. lactate clearance, urine output. A 20-year-old male presents with agitation, tachycardia 160 bpm, and hypertension of P 109 to 100 mHg. He has dilated pupils and is sweating profusely. He denies any drug use but reports taking a new energy supplement he bought online. What is the most likely diagnosis and what is the treatment approach? Answer. This patient is presenting with sympathomimetic toxicity, likely due to the ingestion of a stimulant such as amphetamine or cocaine or a sympathomimetic-containing supplement. The most likely diagnosis is sympathomimetic overdose. Diagnosis. Key features include agitation, tachycardia, hypertension, dilated pupils, and diaphoresis. The patient's history of using a new energy supplement points to a possible stimulant overdose. Management. Sedation. First-line treatment includes benzodiazepines, e.g. lorazepam or diazepam, to control agitation, seizures, and sympathetic overdrive. Supportive care. Provide supportive care, including intravenous fluids, and monitor for arrhythmias, hypothermia, and organ dysfunction. Avoid beta blockers. Avoid using beta blockers due to the risk of unopposed alpha-adrenergic stimulation, which could worsen hypertension. A 32-year-old pregnant woman at 32 weeks gestation presents to the emergency department with sudden onset of vaginal bleeding, abdominal pain, and uterine tenderness. Ultrasound reveals a retroplacental hematoma. What is the most likely diagnosis and what are the immediate management steps to address this situation? Answer. The most likely diagnosis is placental abruption, a condition in which the placenta prematurely detaches from the uterine wall, leading to hemorrhage. The risk factors include trauma, hypertension, and substance abuse, e.g. cocaine use. Management includes stabilization. Establish intravenous ominous access, administer fluids, and monitor for shock. Fetal monitoring. Continuous fetal heart rate, FHR, monitoring to assess fetal distress. Delivery. If the hemorrhage is severe, emergency cesarean delivery is indicated, especially if there are signs of fetal or maternal distress. Blood transfusion. If there is significant blood loss, transfuse blood products. Magnesium sulfate. If the gestational age is 34 weeks and delivery is anticipated, administer magnesium sulfate for neuroprotection of the fetus. Guidelines and laws. The American College of Obstetricians and Gynecologists (ACOG) guidelines recommend immediate delivery in cases of severe placental abruption with fetal or maternal compromise. Fetal heart rate abnormalities are a critical marker in determining the need for emergent delivery. A 27-year-old woman at 36 weeks gestation presents with a sudden onset of severe headache, visual disturbances, and hypertension, BP 106 to 110 mm Hg. She also has proteinuria. She is diagnosed with severe preeclampsia. What is the most appropriate management approach for this patient, and when should magnesium sulfate be administered? Answer. The patient is presenting with severe preeclampsia characterized by elevated blood pressure, BP 106 to 110 mm Hg, proteinuria, and signs of end organ damage. The immediate management includes blood pressure control, administer antihypertensive agents, e.g. libitalol or hydralazine, to control BP. The goal is to lower BP gradually to avoid end organ ischemia. Magnesium sulfate. Magnesium sulfate should be administered as a seizure prophylactic. It is given intravenously at a dose of 4-6 grams over 20 minutes, followed by a maintenance infusion of 1-2 grams per hour. Delivery. Given the severe nature of the condition, delivery should be considered, especially if the patient's BP is not controlled or if there is any evidence of fetal distress or maternal complications. Guidelines and laws. COG guidelines recommend the use of magnesium sulfate for seizure prevention in patients with severe preeclampsia or eclampsia. International Society for the Study of Hypertension and Pregnancy emphasizes the need for close monitoring and timely delivery if maternal or fetal conditions worsen. A 25-year-old sexually active female presents with lower abdominal pain, fever, and vaginal discharge. On pelvic examination, cervical motion tenderness is noted, and laboratory tests reveal elevated white blood cell count and a positive test for Neisseria gonorrhoeae. What is the most appropriate treatment for this patient, and what are the indications for hospitalization? Answer: this patient most likely has pelvic inflammatory disease (PID), commonly caused by sexually transmitted infections like Neisseria gonorrhoeae or Chlamydia trachomatis. Management includes antibiotics. The patient should be started on broad-spectrum IV antibiotics such as ceftriaxone 250 mg/IM plus doxycycline 100 mg orally twice a day for 14 days, with or without metronidazole 500 mg twice daily for anaerobic coverage. Hospitalization is indicated in the following situations: severe illness or inability to tolerate oral medications, pregnancy, tubo-ovarian abscess or an immunocompromised state, failed outpatient treatment or high risk of non-compliance. Guidelines and laws. CDC guidelines recommend empiric treatment for PID based on clinical findings and risk factors. PID management algorithms from the World Health Organization, WHO, stress timely initiation of antibiotics to reduce the risk of complications like infertility. Mrs. Thompson, a 29-year-old woman with a history of tubal ligation, presents with lower abdominal pain, light vaginal spotting, and a positive pregnancy test. On examination, she has a tender adnexal mass and a mild fever. Ultrasound reveals an empty uterus. Given these findings, what is the most likely diagnosis and what should the next steps in management be? Answer: the most likely diagnosis is ectopic pregnancy, where the fertilized egg implants outside the uterine cavity, most commonly in the fallopian tubes. The key findings in this patient: positive pregnancy test, abdominal pain, and empty uterus on ultrasound point to this diagnosis. Management: confirmed diagnosis, perform serial quantitative HCG levels. A rise of 66% in 48 hours is suspicious for an ectopic pregnancy. Surgical or medical management. If the patient is stable and the ectopic pregnancy is small, no fetal heartbeat, methotrexate can be administered to terminate the pregnancy. If the patient is unstable or has a large ectopic pregnancy with significant risk of rupture, surgical management via laparoscopy is required. Guidelines and laws. ACOG recommends methotrexate for the treatment of unruptured early ectopic pregnancies. The Royal College of Obstetricians and Gynecologists (ARCOG) offers guidelines on surgical versus medical management based on the size and location of the ectopic pregnancy. A 19-year-old female presents to the emergency department with acute onset right lower abdominal pain and nausea. On pelvic examination, she has tenderness and a palpable mass. Ultrasound reveals an enlarged ovary with reduced blood flow. What is the likely diagnosis and what is the recommended management? Answer: the likely diagnosis is ovarian torsion, which occurs when the ovary twists around its supporting ligaments, compromising blood flow and causing pain. Management includes surgical intervention. Laparoscopy is the definitive treatment for ovarian torsion. The goal is to detort the ovary and restore blood flow. If the ovary is necrotic, it may need to be removed. Pain management: administer analgesics to control pain prior to surgery. Guidelines and laws. ACOG recommends early surgical exploration in cases of suspected ovarian torsion to preserve ovarian function and prevent complications like ovarian necrosis. The American Institute of Ultrasound in Medicine (AM) emphasizes the role of ultrasound in diagnosing ovarian torsion through the absence of blood flow. A 12-week pregnant woman presents with vaginal bleeding and cramping. Ultrasound shows a non-viable pregnancy with no fetal heartbeat. What are the key management steps for a missed miscarriage, and how should the patient be counseled? Answer: the patient has a missed miscarriage where the fetus has died but has not been expelled from the uterus. Management includes expectant management. In some cases, the patient may opt to wait for the miscarriage to resolve spontaneously. Medical management. If the patient prefers, medications like misoprostol can be used to expel the tissue. Surgical management. If medical management fails or if the patient is unstable, a dilation and curettage (DC) may be necessary to remove the remaining tissue. Guidelines and laws. ACOG provides guidelines for the management of early pregnancy loss, emphasizing patient counseling on the options available and the risks of infection. RCOG recommends offering psychological support following miscarriage. A 34-year-old pregnant woman at 38 weeks gestation presents with headache, swelling in her hands and feet, and high blood pressure 106 to 100 millimeters Hg. Laboratory results show elevated liver enzymes and low platelets. What is the likely diagnosis and what management is required? Answer: the likely diagnosis is HELLP syndrome, hemolysis, elevated liver enzymes, low platelets, a severe variant of preeclampsia. Management: stabilization. Administer antihypertensive medications like labetalol to control BP. Magnesium sulfate for seizure prophylaxis, as HELLP syndrome increases the risk of seizures. Delivery: immediate delivery is often required, especially in severe cases. The patient should undergo delivery via cesarean section if there are signs of fetal distress. Guidelines and laws. ACOG recommends early delivery for patients with HELLP syndrome, typically at 34 weeks or earlier if maternal or fetal conditions worsen. The American College of Physicians offers further recommendations for managing hypertensive crises in pregnancy. Mrs. Garcia, a 29-year-old pregnant woman at 28 weeks gestation, is diagnosed with gestational diabetes after an abnormal glucose tolerance test. Her HbAC level is 6.1%. What dietary and management interventions should be implemented to control her blood sugar levels during pregnancy? Answer: Mrs. Garcia has gestational diabetes and requires a combination of lifestyle modifications and medical management. Dietary modifications: advise a balanced diet with controlled carbohydrate intake, aiming to maintain a steady blood glucose level. Monitoring: encourage regular blood glucose monitoring to ensure optimal control. Insulin therapy: if blood glucose levels are not controlled with diet alone, insulin therapy should be considered. Metformin may also be used as an alternative. Exercise: recommend regular physical activity such as walking to improve insulin sensitivity. Guidelines and laws. ACOG provides clear guidelines for the management of gestational diabetes, emphasizing the importance of glucose control to reduce risks for both the mother and fetus. The International Diabetes Federation advocates for a multidisciplinary approach to managing gestational diabetes involving nutritionists and endocrinologists. 40-year-old woman presents with menorrhagia and pelvic pressure. Ultrasound reveals multiple uterine fibroids. What are the management options for fibroid-associated bleeding, and when should surgery be considered? Answer: the management of fibroid-associated bleeding depends on the severity of symptoms. Management includes medical therapy, hormonal treatment, e.g., oral contraceptives, progestin intrauterine device (IUD) or tranexamic acid to reduce bleeding. Surgical options: surgical intervention including myomectomy, removal of fibroids, or hysterectomy, removal of the uterus, should be considered if the fibroids are causing significant symptoms or if other treatments fail. Uterine artery embolization, an option for patients who wish to preserve fertility but is symptomatic from fibroids. Guidelines and laws. ACOG provides guidelines for managing symptomatic fibroids, recommending medical treatment for mild symptoms and surgical options for more severe cases. The Royal College of Obstetricians and Gynecologists (RCOG) provides further detail on the indications for surgery. The 25-year-old female presents after a motor vehicle accident with vaginal bleeding and a suspected vaginal laceration. On examination, there is a deep laceration of the vaginal wall. What steps should be taken to manage this injury, and what are the potential complications to be aware of? Answer: vaginal trauma requires careful management to prevent complications such as infection and hemorrhage. Management includes hemostasis, control bleeding by applying direct pressure and suturing any lacerations. Pain management: administer appropriate analgesia, e.g., local anesthetics or systemic pain relief. Assessment for further injury: perform a thorough examination to rule out other injuries such as uterine rupture or rectal involvement. Antibiotics: prophylactic antibiotics may be indicated to prevent infection. Guidelines and laws. ACOG offers detailed guidelines on the management of vaginal lacerations, emphasizing proper repair and infection prevention. The American College of Surgeons (ACS) provides guidelines on trauma management, including vaginal and pelvic injuries. Ecopediatric patient experiencing a severe bradycardia, heart rate less than 60 beats per minute. What steps should be taken according to the PALS protocols, and why are these interventions crucial in this setting? Answer: according to the Pediatric Advanced Life Support PALS guidelines, the first step in managing a child with bradycardia is to assess the ABCS airway, breathing, circulation, and initiate appropriate resuscitation. If the bradycardia is causing poor perfusion or signs of inadequate circulation, immediate intervention is necessary. Step 1. Ensure a clear airway and administer supplemental oxygen if required. Step 2. If the heart rate remains below 60 bpm despite effective ventilation, begin chest compressions. Step 3. Administer epinephrine 0.1 mg of 110 0 concentration IVO every 5 minutes during resuscitation efforts. Step 4. If bradycardia persists, consider the need for advanced airway management and possibly pacing or the use of atropine for vagal-induced bradycardia. These interventions are crucial because the primary goal in pediatric resuscitation is to restore adequate perfusion to vital organs, especially the brain and heart, and to prevent irreversible damage due to prolonged ischemia. What are the key differences in airway management techniques between pediatric and adult patients, and why is it important to recognize these differences? Answer: key differences in pediatric airway management include anatomical differences. Pediatric airways are smaller and more prone to obstruction. The larynx is located higher, more anterior, making intubation more challenging. Additionally, the tongue is larger relative to the oral cavity, increasing the risk of airway obstruction. Airway resistance. The pediatric airway has higher resistance due to its smaller diameter, making breathing and ventilation more difficult. As a result, securing the airway as quickly as possible is crucial. Breathing patterns. Children have a higher respiratory rate than adults, and their oxygen consumption is also higher, meaning they desaturate more rapidly in cases of respiratory distress or failure. Understanding these differences helps healthcare providers apply pediatric-specific techniques such as the use of age-appropriate endotracheal tubes positioning and the use of pediatric-specific ventilation strategies. Mr. Smith brings his 3-year-old daughter, Emily, to the emergency department after she was involved in a car accident. Emily is conscious but lethargic and has signs of hypovolemic shock, including a capillary refill time of 4 seconds, decreased urine output, and tachycardia. Given these clinical findings, how should Mr. Smith's daughter be managed according to pediatric trauma resuscitation protocols? Answer: in the case of Emily, the child is showing signs of hypovolemic shock due to potential blood loss or dehydration. According to pediatric trauma resuscitation protocols, the following steps should be followed. Initial assessment. Secure the airway, breathing, and circulation acts. Provide supplemental oxygen to ensure adequate oxygenation. Fluid resuscitation. Begin fluid resuscitation with isotonic crystalloids, such as normal saline or lactated ringers, at a rate of 12 AG bolus. This should be done rapidly to correct hypovolemia. If no improvement is noted after the initial bolus, a second bolus of 12 mAg may be required, and more advanced measures such as blood transfusion may be considered if there is suspicion of significant blood loss. Monitor and reassess. Continuous monitoring of vital signs, urine output, and capillary refill is critical to assess the effectiveness of the resuscitation. In addition, consider imaging to evaluate for internal bleeding or fractures. What is the initial pharmacological management for a pediatric patient presenting with an asthma exacerbation, and what is the rationale behind the use of these medications? Answer: in the case of an acute asthma exacerbation, the following pharmacological treatments are recommended. Short-acting beta-2 agonists, SABA. Medications such as albuterol are used as first-line therapy for bronchodilation. They work by relaxing smooth muscles in the bronchial tree, thereby opening up the airways and improving airflow. Corticosteroids, systemic. Prednisone or prednisolone are administered to reduce inflammation and prevent the exacerbation from worsening. This helps control the underlying inflammatory response. Ipratropium bromide. In cases of severe exacerbation, ipratropium, an anticholinergic, can be used in combination with SABs to further reduce bronchoconstriction. These medications are critical for managing acute asthma exacerbations and improving oxygenation by opening the airways and reducing inflammation, which is key to preventing respiratory failure. A 5-year-old patient presents with fever, lethargy, and signs of systemic inflammatory response syndrome says, what clinical criteria should prompt the diagnosis of sepsis, and what initial treatment measures should be implemented? Answer: sepsis in children is diagnosed when there is evidence of infection and at least 2 of the following criteria of SIRS. Fever above 38.5 dec or hypothermia below 36 dec, tachycardia, heart rate above 160 bpm in a 5-year-old, tachypnea, respiratory rate greater than 60 breaths per minute, leukocytosis or leukopenia. In the case of suspected sepsis, early recognition and rapid intervention are essential. IV antibiotics. Broad-spectrum antibiotics e.g. ceftriaxone, vancomycin should be administered within 60 minutes of identifying sepsis. Fluid resuscitation. Administer 20 mg of isotonic fluids rapidly to restore circulation. Vasoactive medications. If hypotension persists despite adequate fluids, inotropes such as dopamine or norepinephrine may be necessary to support circulatory function. This early aggressive management aims to prevent shock and multi-organ failure, which are common causes of morbidity and mortality in pediatric sepsis. What is the management strategy for a child presenting with a febrile seizure, and when should further investigation or treatment be initiated? Answer: febrile seizures are common in children aged 6 months to 5 years. Management involves ensure safety by positioning the child on their side to prevent aspiration and injury during the seizure. Observe and time the seizure to ensure it is brief, less than 5 minutes. Most febrile seizures are self-limited. Antipyretics. Administer acetaminophen or ibuprofen to manage fever and comfort the child, although these medications do not stop the seizure. Seizure prolongation. If the seizure lasts longer than 5 minutes or if there is a history of recurrent seizures, benzodiazepines e.g. lorazepam may be indicated to stop the seizure. Further investigation is required if the child has focal features during the seizure, there is a family history of epilepsy, the child is over 5 years old, or the fever is not the typical cause of the seizure. What are the critical steps in managing a pediatric patient suspected of having bacterial meningitis, and what are the most common pathogens in children? Answer: for pediatric patients suspected of bacterial meningitis, immediate actions are required. Start IV antibiotics as soon as possible, e.g. ceftriaxone or cefotaxime, ideally within 60 minutes of suspicion. Corticosteroids, dexamethasone, administered to reduce neurological sequelae, particularly in cases of suspected Haemophilus influenzae type B. Supportive care, hydration, pain management, and antipyretics. Common pathogens in children include Streptococcus pneumoniae, Neisseria meningitidis, and Group B Streptococcus in neonates. Prompt treatment is crucial to prevent severe complications such as hearing loss, seizures, or death. What are the benefits of using trauma scoring systems such as the Pediatric Trauma Score (PTS), and how does it assist in clinical decision-making? Answer: the Pediatric Trauma Score (PTS) helps identify children at risk for severe injury and assists in determining the need for advanced care. The PTS assigns points based on physiological factors like Glasgow Coma Scale (GCS) and systolic blood pressure, anatomical factors such as head, chest, and abdominal injuries. Mechanism of injury, such as falls from a height or motor vehicle accidents. The score helps guide clinicians in determining the severity of trauma and informs decisions about whether the patient should be transferred to a higher level care facility. High-risk patients should be monitored closely for deterioration. What are the most common signs of abdominal trauma in pediatric patients, and how is this condition typically managed? Answer: abdominal trauma in children may present with pain or tenderness in the abdominal region, especially the right upper quadrant in cases of liver injury, distension or visible bruising, e.g. seatbelt marks, hypotension due to blood loss. Initial management includes fluid resuscitation with isotonic fluids, imaging such as ultrasound or CT to assess for organ injury, surgical consultation if there are signs of hollow organ perforation or significant internal bleeding. The goal is to identify and manage bleeding, prevent infection, and support organ function. What is the first step in the management of a child with burns, and why is early intervention critical in pediatric burn cases? Answer: the first step is stabilizing the airway and ensuring adequate oxygenation. Burns in children require rapid cooling of the affected area with cool running water for 1 euro, 2 euro minutes and removal of burned clothing. After initial stabilization, fluid resuscitation with the Parkland formula 4A G% burn should be initiated. Pain management and tetanus prophylaxis are also important components of care. Early and aggressive management of burns is essential to prevent hypovolemic shock, sepsis, and long-term morbidity due to scarring.